Okay, let's start. Okay, so as I said, like you don't worry about whatever they're saying here. I'm gonna give you the information here. Okay, so now this is a 6-day-old female who presents with poor feeding and decreased responsiveness. Okay, so heart rate is 150, respiration is 62, blood pressure 75/43. So and she present to the emergency room. Let me show you. And the history, she present with a decreased number of wet diapers. Okay, and she's somnolence, irritable. Okay, so she has sign of sepsis, decreased intake, less responsive. Okay, so
Okay.
this is the history that you can take. That's the most important thing. And she presented to the emergency room. Okay, confirm. So so what do you do right now for this patient?
So we do ER orders, IV access, normal saline. Um, do we put cardiac monitor, blood pressure monitor?
Yeah, you can do that. So you do IV access, cardiac monitor. You said BP
Mm-hmm.
monitor.
No.
What else? Oxygen.
Mm-hmm.
And we
Yeah.
do CBC, BMP.
Okay.
What else?
What time?
Because it's an infection, you know the infection workup. What is the infection workup?
Okay, so we do blood culture
Yeah, okay.
and do empiric antibiotics,
And then urine culture also.
urine culture.
I want to know where is this coming from. Okay, and then you can do CSF culture because it could be meningitis, right?
Okay. Well, we do like lumbar puncture right now. We shouldn't,
Yeah, you
even though
can.
we have a fever.
Yeah, you can order it.
Okay.
And then we do chest X-ray because it's pneumonia.
Yeah.
Okay, and then inflammatory markers, C-reactive protein, ESR. Okay, those are important, right?
Mm-hmm, mm-hmm.
Okay, so let's do those. You know, in the real exam, it can be slow too, so you gotta be careful with that too.
So you can do fungal culture also?
Yeah, you can order that too. It doesn't hurt, like, because you're taking the CSF anyway, so it's not an invasive procedure. Chest X-ray. Selective protein. Okay. So now, what do you want to do?
We do like physical focused.
Okay, that's a good thing. So that while we get the results of the.
Mm-hmm. Do we do a CT in this case? Had CT or no?
No, it's just 6-year-old girl. So try to avoid radiation as possible. And the other test can tell us stuff too.
Would you do a neuro exam on this girl?
Yeah,
Or not?
yeah, you can do neuro exam too. You can do neuro exam in case meningitis and stuff. You can even do skin exam if it's dehydrated and stuff. Okay, so the physical examination, the pulse oximetry shows 91%, and lungs are clear bilaterally, but there is mild subcostal and suprasternal retractions. Abdomen is non-tender on her physical. Hint, normal cephalic atraumatic. Everything is fine with hint. So now let's check the lab results.
Okay.
Let's advance the clock. This is a good way. Like you can advance it like 3 hours, and then you can stop it whenever it's necessary. Okay. So now you get the labs. The labs, you found chest X-ray, you found diffuse reticulonodular pattern bilaterally, and slight hyperinflation, and small right pleural effusion. White blood cells 16,000. Hematocrit is fine. Hemoglobin is fine. Okay, sodium is fine. Potassium is fine. Chloride is fine. C-reactive protein 2.7. That's fine. The blood culture is pending. Okay, urinalysis, you found 1 to 4 white blood cells, negative esterase and negative nitrate. Lumbar puncture was performed, no gram stain, no neutrophil, so it's not unlikely to be meningitis and stuff like that. Okay, so it's most likely, it looks like a lung infection. Okay, so now what do you want to do after seeing those lab results?
Well, chest X-ray.
Yeah, we did that, chest X-ray.
So then admit her and
Excellent.
give her.
Yeah, I admit her. So just send her to the inpatient. So
we send her to regular ward, right?
Yeah, just to the floor. Yeah. Now, when you admit her, what do you want to do?
Urine output.
Yeah, we do vitals every 4 hours. Yeah, output, you can do that. What else?
Bed rest. Diet.
You give her IV fluid. Yeah, bed rest, you can do that too. What else do you want to do? You want to give her antibiotics?
Yeah.
Which one?
Zofin.
Yeah, ampicillin and cefotaxime. You know why?
Why?
Yeah, ampicillin for gram positive and cefotaxime for gram negative. Even if it's GPS, then we will detect that. Okay. And then we order CBC and BMP every day, Q daily, just to monitor the infection. That's for an infection. Okay. And I can put her. We put her on NPO. If the respiratory rate more than 60. Okay, so we put her on NPO. Now that's it. Do you want anything else? No, saline. Just dehydrated. Okay, because she's like unstable right now, she just monitor the vitals every 4 hours. Heavy fluid, normal saline. Intravenous.
So since she's 6 years of age, do we add steroids or no?
I'm sorry? I'm sorry, what did you say?
Oh, no. I was asking if we add steroids for her.
No, why do you want to add a steroid? Like, what's she has an infection? Steroid would worsen her condition, like weaken the immune system. Cefotaxime IV. Okay, CBC. How often do you want that?
24 hours.
Yeah, every 24 hours. Because like this, you can do it for any infection that you have.
Mm.
On BMP, is the same. Okay, so now the blood culture is back and grow gram-positive cocci in chain. Likelihood of GPS is very high.
Mm-hmm.
So what do you do right now?
Well, gram-positive cocci chain, that's strep, right?
Yeah, group B strep.
Yeah.
This one we already ordered it. So what do you want to do right now? So the antibiotic that we given, is that good for GPS, for culture, for our culture result?
Yeah.
Yeah, so that's a good. So now all what we can do is just re-examine her every 2 to 4 hours because this is acute. It's not like she's someone a postmenopausal 50 years old. I just see her like every 8 weeks or so. No, this is like acute. So we monitor her like so. There are some cases different with CCS. Some cases you monitor every hour, every 2 hours, like this. You check on her because she's very unstable and she could be gone anytime. While some office cases, okay, you monitor every 8 weeks, every 6 weeks. Some office cases you monitor every 2 weeks, every 1 week, something like that. So for these types of patients, even the timing for them, it's gonna be short. Like if you advance it for 3 days, that's it. The case will end. That means you didn't do well. Like if it's acute, even if you look at it for example, COPD exacerbation case, it has a limit of 4 hours.
Mm.
Yeah. I chose this type of case from the US Family Practice case because it's this girl. I feel bad for this girl. She has rheumatoid arthritis and stuff, and we're admitting her and doing everything. She just has arthritis, but this one is 20 minutes and takes couple of weeks. So that's why it can fit for all the other cases. So that's why I'm using it as an example for everything. Okay, so now you examine her every 4 hours. Now her temperature is down. Her oxygen is improving right now. Respiratory rate less than 60. So what should you do right now?
Just continue to monitor her.
Yeah, just continue monitor. You can keep her like in the ER, like in the inpatient for 2 days or so. And then if she has any problem, then you can just address that. If there is electrolyte abnormality or anything like that, you address that. Like so, for example, if that patient have a CSF infection,
Mm-hmm.
okay, so what could be the organism?
Strep pneumonia.
Yeah, it could be. Yeah. So what are the other causes of respiratory infection?
Other causes of it? What do you
What
mean? Like,
bacteria? What bacteria?
oh, strep pneumonia is another one. Haemophilus influenza. Well,
Yeah, excellent. Yeah, and listeria and anaerobes too.
right.
Okay, so what are the risk factor for GPS infection in unit?
Infected mom.
Yeah, excellent. Infected man. Yeah. And so what antibiotic regimen that we have for that?
That I don't know.
Yeah, ampicillin and cefotaxime, the one that we just heard. Okay. That's we monitor her every 8 hours.
Hmm.
Okay, that's an important thing.
So in the beginning, how did we know this was sepsis?
So this is the signs of sepsis. There's a table even in your ward. They have decreased responsiveness,
Hmm.
fever, irritability, and decreased wet diapers.
Hmm.
Okay, that's a big sign for sepsis. Especially
Okay.
decreased wet diapers, that's very specific for that. That means they're dehydrated and with fever, boom, that's a specific finding for sepsis.
Okay.
Okay. How about if the mom has a herpes? Then what antibiotic do you give her?
Then you give her acyclovir, right?
Yeah, exactly. You give her cyclic. So you just be flexible, like to the depend if they change the case. So you should be ready for anything that come on the way. So this thing, okay? Yeah. So that's about this case. Okay. Now let's go to the next case, and then you just consult parents.
Hmm.
Okay. Okay. Let's go. So now this patient, 7-year-old boy, who present due to altered mental status and
Hmm.
stumbling.
Okay.
Okay. His vital signs: blood pressure is 108 over 75, heart rate is 88, respiratory rate is 8.
Okay.
Okay. Temperature is 36.
Hmm.
He was found confused and stumbling, and then he became less responsive, garbled speech, somnolence. Okay. He went to school that day and come home appearing to be normal at that time, but then he went to the schoolmate house and then he returned several hours later with the symptoms above, like irritability and stuff like that.
Okay.
Okay, so he's in the emergency room right now. Review of system: no headache, no fever, no photophobia or rashes. His development is normal. Okay, so now he's in the emergency room. So what do you want to do?
So that's the thing. He's a kid. What do we do in a kid that has altered mental status?
Yeah, now we're gonna see. First, let's start first thing first. What is it? Pulse ox.
Right.
Okay.
Oxygen.
Oxygen. What else? Card monitor.
Hmm.
What else? You wanna, because it's altered mental status, so we do urine
Okay.
toxicology, and this is what I'm. His respiratory rate is 8, so that's risky a little bit. Okay. We do IV access.
Mm-hmm.
Okay. And then we go finger stick glucose, right?
Okay.
What else?
Do we give him thiamine or no?
Let's give him naloxone.
Okay.
Okay. Case. You can give him thiamine too if you want. But most likely naloxone looks like an opioid, something like that, because respiratory rate is depressed. So let's order all of that and see what's going on. continue that. Let me put a naloxone. Oh, it doesn't show that it's one time. Okay, so now what do you want to do?
Physical focus.
Which one? General heat, chest, lung, abdomen, and do neuro extremity.
Mhm.
So his pulse ox is 94. On physical examination, he's well developed. He appeared diaphoretic. He mumbles a response that cannot be understood, and he doesn't open his eyes to command. He localizes to painful stimuli. Pupil 3 mm bilaterally. Okay, and he has odor of alcohol in his breath. Respiration shallow and slow, and everything else is normal. Finger stick glucose is 48. So what do you do right now?
The 3 mm is pinpoint pupils, right? It's really tight.
Yeah. So
So give him.
he's having hypoglycemia, right?
That's true. That's
Yeah,
true.
okay. D50 you give him. What is it? What else do you want to do?
I
IV
don't know.
fluid, normal saline.
Okay.
He has a breath of alcohol in his mouth, so blood alcohol level. And serum toxicology panel. What
Serum?
else?
No. Serum or urine?
CBC, BMP. We ordered urine, now we order serum. CBC, BMP, and what else? You want to do echo check every hour.
Okay.
Do you want to order anything else?
No, I'm not sure.
I didn't read that. Okay, so they didn't take the D5 dextrose. Let's see. Okay, so now we get the results, right? We just advanced now. Let's get the results. So you found the blood alcohol level is high. The urine toxicology is positive for ethanol. Serum toxicology is positive for ethanol too. BMP is normal. Okay. CBC is normal. Aqua check is normal. Now glucose is fine. So what do you do right now? He's in the emergency room right now.
You give him chlordiazepam or something for alcohol?
Yeah. But first we admit him, right? You just put him in the monitoring him. He needs some monitoring, so we put him to the floor. So we continue the glucose. What did you say? Which one? What do we give him?
I don't know what the thing is. I don't know how to work on kids, so
Yeah. This is like it's challenging. So you put him NPO. That's the first thing. Okay.
Okay.
Put him on IV fluid and give him potassium if he needs that. You do PMP. Okay. You can check phosphorus, magnesium. You can. What else? What do you want to do? Repeat alcohol level in 12 hours too.
Every 12 hours. Okay.
No, after 12 hours, not every time. We check him now. Phosphorus serum. Magnesium serum, okay. Now we just monitor him, advance the clock for a little bit. The patient becomes responsive after 4 hours. Now he's fully awake. Okay. So let's see him the next day then. Okay, so what do you want to do on the next day?
Monitor.
Yeah, We ordered BMP and blood alcohol level.
Mm-hmm.
Now he's fully awake. What do you want to do?
I don't know.
Just discharge him home.
Okay.
So I'm gonna see him next week. Okay. So these things will be discontinued by itself. He's not feeling.
Mm.
Okay, now you wanna counsel him. I don't know what we did to that patient. Counsel him. Okay, what else do you wanna do? Counsel him. Also screen for abuse and domestic violence. So alcohol use. What happened? Okay. Counsel parent. Yeah, and that's about it. So how would you summarize this case?
I don't know. Summarize it for me because I'm lost in the child's case.
So someone who present with respiratory depression and somnolence is a
Mm-hmm.
kid. He comes to the emergency room. What do you do for him? The smell of alcohol in his mouth and everything.
Okay.
First, IER orders, right?
Mm-hmm.
And then you do physical exam.
Mm-hmm.
And then once you find, so initially, so before when you have like somnolence and stuff, you give him naloxone just in case you're suspecting opioid.
Mm-hmm.
And then you do finger stick glucose. That's with the plus the AR orders. And then when you have the glucose is low, you give him dextrose.
Okay.
Okay? And then you're just monitoring. That's the main thing, you know. Most of the time doctors they can't do much, you know. So you just
Mm.
monitor.
Okay.
Okay, so this patient just monitor him. Do BMP every day, echo check if he needs anything. If there is some potassium is low, you give that. If there's glucose low, give that. Give him IV fluid. That's mainly, you know.
Mm.
Today I was so tired and stuff like that, you know. After I was talking all day long and stuff, I wanted to make videos and stuff. I exhausted myself, so I felt feverish, tired and stuff. So
Mm.
what? But then I had some water. I ate good food and stuff. I felt better.
Mm.
So same thing. This kid, just give him IV fluid. You know, it's gonna make everyone better.
Okay.
Yeah. And the hypoglycemia. So this investigate and ruling out what else? What do you want to rule out in this patient?
Oh, what? I don't know. Infection?
Excellent. Infection, trauma, sepsis,
Mm.
other drug intoxication. That's why we are tertiary toxicology. Okay, and begin supportive care with detection and maintenance of airway. That's the most important thing. And IV fluid, correction of electrolyte. That's your job.
Mm.
Correct hypoglycemia. Okay. Most patient will respond well.
Okay.
Okay, as his development is fine and stuff like that. You know, unless you have a cystic fibrosis, then you're not that fucked. We can monitor you for a little bit. You know,
Mm.
like alcohol intoxication is not that bad as having some genetic disorder or some chromosomal abnormalities. You know, this one
Okay.
just monitor him and observe him if there's any
Mhm.
abnormality. Okay, so now let's do. Okay, so now we're gonna do another case. You ready?
Yeah.
Cool. Okay, now 50-year-old guy who present with a headache.
Mm-hmm.
Vital signs are stable.
Okay.
Temperature is 36. Respiratory rate 18. heart rate is 70, blood pressure 140 over 80. So you check the history. You have sudden severe headache develop over the past 2 hours. Female, like 50-year-old female. She has pain 10 out of 10, non-radiating, so she with nausea, no vomiting. She also noticed visual changes, photophobia. She denied fever, chill, or numbness, no loss of consciousness. She says that she's been having tension headache for the past few years and describe it as this completely different and the worst headache of my life. No allergies. She quit smoking and alcohol, but she takes her caffeine, so counsel her on that. Live with husband, no family history of aneurysm or stroke. Medication only fluoxetine and ibuprofen. So what's your differential?
Subarachnoid hemorrhage.
Yeah, what else? She's 50 years old.
Meningitis.
Yeah, what else?
Cold.
Stroke, it's low on the differential, doesn't present with that severe of a pain. Migraine, headache, could be. Subarachnoid, yeah, stroke. Temporal arthritis, glaucoma, tension headache.
Okay.
So what do you do right now?
You tell me. What do we do?
Sorry. So you put her in the emergency room? She's in the emergency room. She presented in the emergency room. Okay, since she's in the emergency room right now, so the first thing, you just do quick physical, very quick, okay? Hand, lung, heart, general. Okay, you do extremity neuro, that's very quick. Because she's stable, so just do it. Okay, so physical examination is normal, but you notice neck stiffness. Everything
So
else is fine.
In this case, we don't do the ER orders first?
Because she's stable
Okay.
hemodynamically, so just a quick physical, doesn't take much time now. So, and then she has left temporal tenderness and neck stiffness. That's the most important thing that you need to know, okay? So what do you do right now?
CT.
Yeah, before that, what do you do? Yeah, you can do CT head. What else? IV access, you want to do that? You want to treat the pain?
Sure. What do we give her?
Ketorolac, some NSAID. Give her, do ESR. Okay. So do you want to do it with contrast or without?
Without.
Excellent. Because I don't want to, because it could be bleeding, so. Ketorolac IV, okay. Continuous. Yes. Okay. So what are the indications for CT in this patient?
What are the indications? I don't know.
So severe headache, worst headache of my life, and sudden onset of headache in age more than 50, and the presence of focal neurological finding, which is neck stiffness here in this patient. Okay, so now let's get the results of our orders. Okay. CT of the head shows absence of subarachnoid hemorrhage. Okay. ESR is normal. The patient is still in mild to moderate pain. What do you do right now?
I don't know. I mean, CT was normal. What would we do?
So that's the thing. In real life, if you have sudden headache, worst headache of my life, and neck stiffness, so subarachnoid hemorrhage is very high on differential. So that's why you gotta order if the CT negative, you do lumbar puncture, xanthochromia, okay? But unfortunately, lumbar puncture doesn't present on the software. It's not here in the software. But in real life, we order lumbar puncture, okay? So now, since it's most likely subarachnoid hemorrhage, so we admit her to the ICU. Okay, so what do you want to do in the ICU right now?
The orders for ICU?
Yeah, put her on PO, bed rest, Yeah, what else?
So what is she having? Meningitis or subarachnoid hemorrhage?
Yeah, we don't know yet, so we'll see what's going. Now our test is gonna tell us because CT was negative.
So
Okay.
do we do blood cultures on her?
Hmm? Yeah, we can do blood culture, but it's not may not tell us anything because
Hmm.
it's high likelihood of to be because she doesn't have fever, so it's high likelihood to be subarachnoid hemorrhage.
Right, okay.
Okay, so we'll just treat her as if it's subarachnoid hemorrhage. So this is what you're gonna do. Okay, so cardiac monitor. What else? What do you want to do? Pulse
That-
ox. You do neuro check
mhm.
every 1 hour. And do CBC, BMP. What else? EKG. What else?
That's it.
Let's do a PT, INR.
Mhm. What for?
In case there's a bleeding, increase hemo. Increase in case like we want to do surgery also. Okay, we consult a neurosurgeon.
Okay.
And what do you want to give her? You want to give her normal saline?
Yeah.
Because this high subarachnoid hemorrhage, that's what's most likely. Okay. What else? Do you want to give her something stronger for the pain?
Yeah, what
Give
can
her
we do?
Percocet, which is acetaminophen plus codeine.
Okay.
What else? What medication do you give for to prevent vasospasm, which is the most important complication of subarachnoid hemorrhage?
Nimodipine.
Excellent, yeah, nimodipine. Yeah, good job. You have really good medical knowledge, like medicine stuff, internal medicine. You could be board certified in psychiatry and internal medicine.
It's okay. Let me just pass step 3.
I
It's
knew
all
I knew you were gonna say that. Yeah, and then we're just gonna monitor for DVT. We do compression devices,
Mhm.
just to prevent DVT. I mean, yeah. Okay, let's go ahead. NPO. Come on, the bed rest. Okay. This one, bit of consult a neurosurgeon, CBC, BMP. It's crazy neurosurgery. Like it's crazy. They stay like for the surgery lasts for 8 hours or so. We did that, and they do two shifts, like one shift for 4 hours and then the other shift. Go for Percocet. Give me a second. Remote the pen. Why do we give her omeprazole?
Stress.
Yeah, because it can have stress ulcer and stuff. Yeah. So what do you want to do right now?
Monitor.
Yeah, I just monitor every 5 hours or so. Now let's just check her. How's she doing? Okay. Let's suppose that she's feeling better. See her next day. How's she doing? And it should end by that time. So what do you think right now? How do you summarize the case?
Please summarize it for me. Wow.
Yeah, so this one is a subarachnoid hemorrhage.
Mm-hmm.
Okay, so she's stable. So that's what do you want to remember first. You get the IP access and manage the pain and order CT. You know that for sure. That's the first step. Okay, that's number one. And the second thing, like when you have a high clinical suspicion for subarachnoid hemorrhage, so you know that you admit her to the ICU because it's sudden worst headache of my life. You know, it's no joke. You admit her to the ICU, and you do all the other orders. I'm sure you know them, like CBC, BMP, urine output, EKG, PT, INR, neurosurgery consult. Okay, but the thing that you want to specific for subarachnoid hemorrhage is you give nimodipine. That's the most specific. And then omeprazole, anyone in the ICU, you put him on, like especially like this patient. Pneumatic, like you do prophylaxis for DVT. Okay, if they're having any symptom, you just manage it. The pain, you give them Percocet, normal saline. Okay, that's about it. You know, our job is not that like it's general undifferentiated medical practitioner. That's what they want us to do. Like they don't ask like about the specific of surgery and stuff like that. So this is the specialist gonna take care of it.
Okay.
Yeah. So this is as in
Mm-hmm.
that's what the internist does. Like
Mm.
just stabilize and refer like this, but in inpatient.
Right.
Uh, family medicine same, but it's mostly outpatient. So how would you summarize it now?
Don't make me summarize it, please. I'm gonna lose it. No, I don't
Huh?
know. If
You're
patients
gonna
say
remember it like if you just
focus physical, and then you do HET CT, CBC, BMP, to whatever, and then you admit the patient and put her on nimodipine. Right? Is there anything else?
okay. How about if the patient has hypertension? How do you manage that?
The same patient?
Yeah, if they have hypertension,
Oh, I don't know. What would you?
labetalol. You just give them labetalol.
Okay. So in this one, do you call consult the subarachnoid hemorrhage one,
What do
or
you?
no?
Yeah, we call consult. We consulted neurosurgeon. Remember?
Okay.
Yeah, obviously.
But we don't put in for any procedure or anything, right?
Yeah, we consult neurosurgeon and he will take it from there. We don't put any
Okay.
procedure.
Okay. Okay.
Okay. How about if they have low sodium?
I don't know. I don't know what to do with that.
Just give them hypertonic saline. That's it.
Okay.
Okay. And just watch out for the risk of central pontine melanosis.
Mhm.
Okay. What are the complications of subarachnoid hemorrhage?
Oh, I don't know. What are they?
Vasospasm and hydrocephalus.
Okay.
Okay. Yeah, that's all what you need to know for this. Like, there are detailed management that's beyond our scope of knowledge.
Okay.
Let me just get some water. Okay, so now we managed a kid with sepsis, a kid with alcohol intoxication, and a kid with like a old woman with subarachnoid hemorrhage. Okay. Some water. Okay. So now we're gonna do another case. Ready?
No, no. No more cases. I think three is more than enough.
What is
No,
it?
no. No, I said three cases more than enough. And my brain can't handle a fourth case right
Okay. So what do you want to do? Like